This is Carrie Frank. I'm with Center for Improving Value in Healthcare. I'm the Vice President of Communication and Marketing. Very excited to have all of you joining us today for our session regarding telehealth in Colorado. We're going to be talking about trends and opportunities that we're seeing in the data and some of the work that our friends at OHI and the Colorado Health Institute are doing to identify opportunities that we have to improve access to care via telehealth. So thank you all for joining us today. I would like to just quickly, for those of you who may not be familiar with Civic, just tell you a little bit more about us. We are a mission-based organization, 501c3 nonprofit. Our real mission is to empower individuals, communities, and organizations on the ground who are aiming to advance healthcare, improve the health of Coloradans, improve the care for Coloradans, and also lower healthcare costs. And we really pride ourselves on being nonprofit and independent and objective organization. We serve a variety of stakeholders across both Colorado and the nation, including clinicians, hospitals, employers, nonprofits, health plans, researchers, and government and state agencies. And really the focus for all of our work and all of these entities who we serve is really the consumer and the patient in the middle and the center of everything that we do. Today, we're going to be talking a lot about an analysis on telehealth that's based on data in the Colorado All-Payer Claims Database. So I just wanted to give folks a brief introduction if you're unaware of what the COAPCD is. It is a state-mandated database that has health insurance claims from across all private and public payers, so Medicaid and Medicare, including Medicare fee-for-service and Medicare Advantage, and all of the major commercial payers, which is over 40 commercial payers in the state. We have claims for over 875 million claims across medical, pharmacy, and dental. And that represents the majority of insured Coloradans in the state, over 80%, over 4.3 million unique lives in the state. So very robust. Really the only claims that we are missing is some of the self-insured employer lives, and then some of the federal programs, including TRICARE, the VA, and Indian Health Services. So today we're going to be talking about public use of the data. We also provide custom analysis, but really the COAPCD is intended to identify opportunities in improving healthcare, again, to improve the health and lives of Coloradans and to save money on healthcare spending. So today we'll be focused on public data that we just released in the sphere of telehealth. And so our agenda today is to review our APCD services analysis for telehealth that we just released a few weeks ago. Kristen Paulson, our Vice President of Innovation and Compliance, will be presenting that work. And then we're very excited to have our friends from OHI and from Colorado Health Institute. We have Stephanie Bennett, who's the State Health IT Coordinator from OHI, Carrie Paycheck, who's the Director at OHI, Sarah Smith, who's the Managing Director of Research, Evaluation, and Consulting for the Colorado Health Institute, and Nina Bastian, who's a program manager at CHI. So we'll be sharing not only what the data is showing from the COAPCD, but then what is actually being done around telehealth here on the ground with our friends at OHI and the Colorado Health Institute. Then we would really love some time with all of you who are participating today to actually share with us how you might be using this data and some of the things that you're interested in doing and some of the work that you're doing on the ground. Give us some feedback on the information that we're sharing, how we can make that potentially better and inform your work moving forward. So that's kind of my most exciting part of the agenda today is hearing from all of you. Just a few things housekeeping wise. We are recording this session and we will be providing a recording of this session. If you have questions that you would like to ask during the presentation, please feel free to put those in the chat box. We may or may not address them immediately. We may save those for the end depending on the relevance, but feel free to type those in and let us know as you go through what kind of questions you might have. So at this point, I would love to turn it over to Kristen Paulson with Civic. Thanks, Kristen.
Thanks, Carrie. So we're going to walk through just some background on the purpose of this specific telehealth analysis, what's included in it, and then we'll go to a live demonstration of the report that we have on our website. So initially, this telehealth analysis was created to really understand what is happening to telehealth services before COVID, during COVID, and then we'll be tracking this in the post-COVID environment, whatever that may look like. This is designed to support the allocation of resources to ensure that telehealth is available across the state to any communities that are in need. This was created as initially a direct request from the Office of eHealth Innovation. Next slide. Next, there we go. So these are some of the basic questions that we started with that we wanted this analysis to answer, looking at trends, the kinds of services people are using, what kinds of diagnoses do patients have, what kinds of providers are using them, and then some of the demographics, geographic and patient demographics around the utilization of telehealth services. Next slide. So here are some, it's a limited list, but here are some of the current and long-term barriers that people experience when using telehealth. On the provider front, reimbursement is very low. You will see that in the report when we flip to the actual analysis. That has changed due to some COVID protections that were put into place, but reimbursement is very low. Problems with technology can lead to longer visits. And then there's the potential to undercut the services that are being provided by the actual in-person facilities, especially in rural areas. From the patient side, the lack of broadband connectivity and lack of smartphones are limitations that really impact rural and low-income individuals. Broadband, is not necessarily available everywhere, and that has a huge impact on whether or not someone can take advantage of telehealth services. They may be unable to afford the communication charges associated with telehealth, and then there's also a perception of a lower quality care with telehealth visits. Next slide. So some considerations and parameters for our analysis. What we're going to be looking at includes claims from January of 2018 through February of 2020. We have an update coming up in a couple of weeks. We have a sneak preview at the end of this webinar of that update, but we'll be having an update on services coming up in just a few weeks that actually goes into really the meat of the COVID epidemic and how that impacted telehealth services. Right now, what we're going to be looking at does not include Medicare fee-for-service data for 2019 and 2020. That information will be included in the October update again, and this is largely based on the Colorado statute that defined the expansion of what is telehealth. So we use that as the basis for defining what was included in this analysis. Next slide. So briefly, and again, this information is available both on the website and will be available on the webinar when we post it. The definition of telehealth included both real-time interactions, so interactions across a digital interface, so whether it's a telephone or face-to-face over HIPAA-approved Skype, what have you. Store and forward transfers or asynchronous interactions. These would be between patients and providers using, say, a patient portal used to do patient management. And then services provided through any HIPAA-compliant interactive communication or application using a cell phone, and then voice-only telephone communication and text messaging. Next slide. The exclusion. So this does not include anything using a fax machine. This does not involve regular emails and any sort of email system that's not protected. Provider-to-provider consults are not included, so this is just patient-to-provider consults. There's a lot of provider-to-provider work that happens, and those are not included in this analysis. So definitions of that's okay, next slide. Definitions of telehealth versus telemedicine. So telemedicine specifically is that synchronous interaction, so either on the telephone or through an interactive visual communication like we're doing right now, is telemedicine. Telehealth is a broader scope of services. So that includes additional pieces such as remote monitoring through smart scales and blood pressure. It includes those portal communications. And then Centers for Medicare and Medicaid Services also include their transitional care management codes in the definition of telehealth. So we included that in the analysis that we did. And so those are 30-day periods that can have a telehealth component. And so they are considered part of the telehealth umbrella. Next page. So this analysis is looking at both telemedicine and then telehealth using asynchronous communication, remote monitoring, and transitional care management. And we do have the ability to break that apart. And we'll show you that when we get there. So here are some of our initial findings from this first cut at this report. Again, we're going to be updating these findings and updating the report in the next couple of weeks. But from January 2018 to February 2020, we were already seeing increasing use of telehealth across the board for commercial, Medicaid, and Medicare Advantage members. You could see the Medicaid population specifically had a pretty significant increase over that period of time. We found that women were using telehealth services more frequently than men, and that the 18 to 44 age group used those telehealth services more than other age groups. We also found that mental health conditions were the most frequent use of telehealth visits, followed by respiratory conditions and counseling. Interestingly, this is not noted in the findings, but we also found that there were significant numbers of out-of-state providers being utilized for some of these mental health visits. Primary care providers and behavioral health providers were the most common providers. And then we had, unsurprisingly, Alamosa County. They led the state with the highest overall telehealth utilization rate. And 93% of the visits in that county were for mental health conditions. Alamosa tends to be a bit of a leader when it comes to some of these new ways to access healthcare. And then across the commercially insured population, patients increased their use of telehealth to access these behavioral health providers by 83%, which is a huge increase. Next slide. Okay, I think, Carrie, if you want to stop sharing your screen, I will share the analysis. Okay, so this is available on the civic.org website. We have a drop-down menu for COVID-19 analyses specifically, and this is the telehealth services analysis. This is the first page we're going to be looking at. So this is including all of telehealth in Colorado. Here's the time period slider, so we can adjust this to look at more specific time frames if we would like to. I'm going to leave it at January 2018 to February 2020. We have a payer type drop down, so you can select whether you want to be looking at commercial, Medicaid, Medicare Advantage, or Medicare fee-for-service. We have a telehealth service category. So here we have those 4 kinds of telehealth that we've included in the report. And then whether you want to look at cost or utilization. I am, just for simplification of demonstration, I'm going to actually select telemedicine as a telehealth service category so we can get an idea of how specifically telemedicine is being used across the state from this. So you'll see here the total number of services for the time period selected and the total payments associated with those services, utilization rate, and then the reimbursement rate. So you could see that the reimbursement rate is very low in this situation. Now, this is 28 cents per member per month. It's not per interaction, but that's still a very, very low reimbursement rate. Here we've got an idea of who's actually accessing telehealth. You see that female versus male split as far as who's using the services. And again, here's that 18 to 44 age range were the primary users of telehealth. As we look down, we can also see what the top conditions are, the top diagnosis categories. So why is telehealth being accessed? Mental health conditions, respiratory conditions, counseling, and then what services are being provided. So this gives an idea of what's actually happening within the visit and then again, who is providing those visits. And you'll see that for telemedicine, the delivery is almost split evenly between primary care and behavioral health for those leading providers. And then here we've got an overview of the state where we can pick a county and hover over a county to find out how what variation looks like across the state, county by county. So if we look at Alamosa County, they've got a utilization rate of 171, just 172 basically services per 1,000 members, compared to the statewide average of 50 services per 1,000 members. So the utilization in Alamosa is significantly higher than it is in other parts of the state. And you'll notice that, unsurprisingly, a lot of our rural areas have got much higher utilization rates for telemedicine than we do here in the heart of the urban part of Colorado, and we're seeing lower than average. Adams County at 45.6 services per 1,000 members. So, and again, if you want to click on any one of these, you can actually click on that, and then the rest of this will filter for Alamosa County specifically. So now we can look at exactly what conditions are being serviced in Alamosa, what kinds of patients, what kinds of services, and then what kind of providers are using the services in Alamosa. Up at the top here, we can now switch to telehealth trends to look at some of the trends over time in more of a map or a trend line format. Again, I'm going to go with telemedicine just because it's sort of easier to parse what is going on when we're just looking at one of these telehealth service categories. So we're focused here on utilization per 1,000 members, and you can see over time there's a general upward trend in the utilization of telehealth services. It's not enormous, but we went from approximately 40 visits per 1,000 members to just around 70 on average. Dropped a little bit in January 2020. One of the nice features about this trend line analysis is that you actually have the ability to lasso a few points and look in more detail at what is happening over that period. So if I want to see what's going on during this drop that happened in about June of 2019, I can select those and I will have a month-over-month comparison that shows me where things are going up, where things are going down, and the percent change over that period of time. So I can see what services were driving the decrease in utilization. Okay. And then if we scroll down, we've got this detail page that really drills down to get a little bit more information about the different pieces of information we've been providing. So again, I'm going to limit this to telemedicine. And now we can actually look at these and see if you hover over the specific procedure or diagnosis of interest, you can see that overall change from January 2018 to January 2020. And again, we can change that time period using the slider at the top if we'd like to. But so you see the telephone services remaining pretty stable. Office and outpatient E&M, the 1.7% overall change. We can look at these provider types and see what that trend line looks like. So we can see if there's been a change in the division between primary care and behavioral health being the primary providers of telehealth services. And here we're seeing an increase in behavioral health providers using the service. So 26% overall change in the selected time period. And if we click on behavioral health, there we go. There we go. So that's just a very rough overview of what we have in the telehealth analysis. Again, there's a lot of options you can look at. This piece can be limited by DOI region. So if you'd like to select a specific DOI region, they will filter the rest of these pieces based on that DOI region. You can use cost or utilization, and again, limit by payer type if you want to drill down to one specific population. So that's what I'm going to stop sharing. Carrie, if you want to pull up your slides. And that was a very quick overview, I know, and I'm happy to go back and go into more detail if folks have got questions. And I know we have Katie Oberg on the phone as well, who is our primary analyst driving this, and she can answer any detailed questions that are beyond my capacity. I think we have a couple in the chat box. Oh yes, we will be sharing the PowerPoint or the slides.
I think that's all we have at the moment. Kristen, if you want to let people
Sure.
know our plans to update.
Yeah. So the Colorado APCD updates every other month. We get a new data refresh. We're going to be following what happens in telehealth over the next several months to find out, you know, what's going on, what are the trends, and being able to track that as close to real time as possible. So the data for commercial, Medicaid, and Medicare Advantage has about a 5 to 6 month lag. So the update in October is going to go through, I believe, May. Is that correct, Carrie? It's going to be going through May.
Well, actually, it should be June. It'll be June.
The next
June. Yeah.
Okay. So we're doing April through 2020 in our October refresh, or October of this report, and then we'll be doing through June of 2020 in December. And we'll continue updating this so we can just sort of see what happens as we go along. And I think, is a sneak peek the next slide, Carrie? This, keep in mind, this is still draft. Please don't spread this far and wide because we're still checking and making sure that this is, you know, accurate. Because you'll notice a rather dramatic vertical line jumping up from February 2020 to April 1st of 2020. I think we had to go through and rescale all of the trend maps just because there was such an enormous increase in utilization. So it's going to be very interesting to see what happens over the next several months to find out how this continues to change. Are we still going to see this just astronomical increase? How far will it go? We don't know. So this is just a snapshot of what we're going to be including in the update. Again, Medicare fee-for-service will also be included in this next update through 2019. Medicare fee-for-service has a longer lag time than other payers just because of the way that they submit data. So they're always going to be lagging a little bit behind, but we will have updates on all of our payers, and we will be able to continue watching this crazy, crazy vertical line as it increases as telehealth medicine increased across the state. So I think we're going to be switching now.
Thank you.
I think we're switching now to talk a little bit about how our partners are going to be using some of this data.
Yeah, and before we do that, I just wanted to let everybody know, as I mentioned earlier, Civic, since we are regularly updating this, we are collecting feedback on how we're presenting this information. And I mean, this is a lot, just even this right here, lassoing 3 months of data is a lot of information. So if anybody has suggestions on how we can make this more user-friendly or explain things in different ways or add different elements that we maybe haven't and take away things that aren't helpful, we are definitely open to feedback and would love for you guys to either reach out to us after or you can chat in the chat box. And again, if you have any questions on what Kristen just presented, please let us know. We'll take those questions at the end. But yes, we do want to move on to our friends at Office of eHealth Innovation and eHealth Commission and our friends at the Colorado Health Institute, because you guys are doing some amazing work and it's cool to look at data, but I think it's even more exciting to understand like what's actually happening and how things are changing for people on the ground. So Stephanie, I think I'm turning it over to you. If that's not accurate, let me know. But Stephanie Bennett is here and she is going to let you guys know what OHI is up to in telemedicine.
And Carrie's going to start us off, so she will take it away.
Oh, sorry.
No worries.
Another Carrie. We have lots of Carries and Stephanies with us today. So.
Perfect. So can you hear me okay?
Yes, thank you.
All right, good afternoon, and thank you for having both Stephanie and I here today to talk about our state efforts. We're going to zoom a little out, but do know we are big fans of having data that we can dig into to, one, understand what our baseline is and where we made some assumptions early on, especially during the pandemic. And then 2, where do we go next in terms of infrastructure, policy coordination, and think that telemedicine is one of those evolving policies and technology that we're very interested in. So in terms of the zoom out, just to introduce myself, I'm the director of the Office of Health Innovation, and Stephanie's Colorado's 5th State Health IT Coordinator. Really pleased to have her on the team. Our office works under the Lieutenant Governor to advance Polis and Primavera administration's health priorities through health IT, health information technology, and data sharing. And so I'm just going to give a little bit of background around our office for those that aren't familiar, and then talk a little bit about our pandemic response, telemedicine work, and then hand it off to Stephanie to dig into specifics of projects, insights from our initial efforts with both Civic and CHI, as well as some other nuances. So OHI, if you can go back to the prior slide, just to give you a sense. So our office was established through an executive order. We continue the work to date because I think there is a need for a neutral and fair entity to coordinate policy, funding, and efforts across the state. We're also the state designated entity for American Reinvestment and Recovery Health Information Technology, also known as ARA High Tech. That is sunsetting next year. Who knew we would see the end of that? But that is coming. It's one of the largest sources of funding for connecting siloed electronic health records, as well as advancing the meaningful use of those systems and our health information exchanges. This executive order also established the eHealth Commission, a governor-appointed committee to advise OHI and the state and steers our state strategy known as the Health IT Roadmap. The commission is made up of a number of appointed by the governor experts in health, health information technology, finance, digital health, public-private, not-for-profit organizations. And just wanted to highlight that we are actively recruiting for new eHealth commissioners to fill several upcoming vacancies. So we have 3 individuals that will be terming out and are looking to increase our diversity and inclusiveness, as well as ensuring that we're tracking on evolving technologies and policies. So please share this opportunity with your networks, as well as reach out to me directly if you know anyone that would be a great fit for this work. Prior to the pandemic, our strategies were largely focused on advancing policy, funding roadmap projects. These projects advance strategies, infrastructure, policy, and innovation as outlined in this framework. And although we've changed a lot to respond to the pandemic, we continue advancing these priorities, as well as a laser focus on innovations such as telemedicine and find the data presented by Civic. Really important to ground us, as well as you'll hear later on from CHI. And then more so than the pandemic response, we are focused on integrating behavioral and physical health, and just want to highlight for folks that the Behavioral Health Task Force released their blueprint last week, and one of the key priorities in that blueprint was to advance telebehavioral health in the blueprint. So make sure you get a copy of that if you don't already, and let's collaborate on that. Next slide. So the pandemic telemedicine response, a number of you on the webinar, as well as in the periphery, were engaged. I think Colorado is a unique place for collaboration and engagement. And early on, we saw people willing to accelerate care in new and different ways at the onset of the pandemic. Many folks have been working on telemedicine for over a decade, and it was our assumption that not a ton of people had adopted that. And now that we've got access to Civic's data set, that was actually confirmed, and you can see the jump, and look forward to seeing more in October about the increased utilization. But for the governor's office and lieutenant governor's office and administration, they wanted to harness the power of the private sector in partnership with the state. And so they launched the Innovation Response Team Task Force, also known as IRT, to respond faster and more effective to the emergency response. That spun up a number of work streams, from personal protective equipment, PPE, to testing and isolation, and telemedicine. And for the telemedicine response, I was reassigned to lead as chair, and excited and thrilled by the engagement of the community. I think our goal that we established early on was to ensure that Coloradans, providers, had access and use to telemedicine when clinically appropriate for the majority of Coloradans, through collaboration policy incentives. And again, if you dig into the civic data, you can see that some of our earlier assumptions are validated, and that we were able to achieve our goals later on, but there's still a lot of work to do. As IRT kind of wrapped up, we evolved and transitioned the work to state agencies, and that includes continuing the work through the Office of eHealth Innovation. Mentioned early on, there were a number of executive orders and new Senate bills that came up through this work, and we've highlighted a few of them there. The most recent legislation expands insurance reimbursement for telemedicine services, clarifies the method of communication, and specifies providers included in healthcare and mental health services. In addition to policy, IRT launched communication and pilot efforts in partnership with our office, and we're moving full steam ahead. So thank you for letting me introduce the work that we're leading, and I'm going to hand it off to Stephanie Bennett, Colorado's Health IT Coordinator, to talk about state telemedicine, our specific project efforts.
Thanks, Carrie. And Carrie, the slide driver, you can actually go back, and we kept it light on slides today, so we can hang out on this slide for a little bit. Thank you.
Sounds good, sure.
So as part of IRT, as Carrie mentioned, our office, or OHI, led several efforts to expand the communication, policy, and technology to ensure that telemedicine was widely used by patients and providers. So for communication, we created the Health at Home website to ensure that Coloradans have access to information about accessing telehealth in plain language. In support of state policy, we coordinated a policy task force to identify and share policy needs to expand access and utilization of telemedicine, as well as to share a central source of updated policy information across the state. In the technology space, we are working to accelerate the use of telemedicine through pilots and projects, and are also focused on the interoperability of these records through Health Information Exchange in Colorado. To tie all of these aspects together, we're working with Prime Health to coordinate regional learning collaboratives and Colorado Health Institute to evaluate the access to and use of telemedicine throughout the state. So diving a little bit more into communication, in support of the rapid expansion of telemedicine, we coordinated and led the telemedicine communications work group. The stakeholders in this group recommended more information for Coloradans in plain language about telemedicine in both English and Spanish, just as a result of, as Kristen spoke to earlier, this was such a rapid expansion that a lot of people throughout the state were not familiar with telemedicine, were maybe intimidated by the technology, and just needed kind of a landing page to start their telemedicine journey or exploration. So the result of that was the Health at Home website, and I'll put that link in the chat, or we've linked it in our slides as well that will be distributed. And this website is intended to provide that education and encourage access and use of virtual visits with an individual's provider through their insurance, or using free resources that were stood up, from my understanding, mostly in response to the pandemic. So there are lots of free resources, even if someone doesn't have insurance or a regular provider. And as I mentioned, this website is intended to be a landing page and launching point for Coloradans first learning about telemedicine. For the policy side, we coordinated and led the IRT Telemed Policy Work Group in conjunction with the Colorado Health Foundation. And this work group captured the quickly changing policies at both the state and federal levels in healthcare in one tracker for us all to be aware of and know what's going on. And it also identified the needs and gaps to ensure planning and promotion of telemedicine for when those emergency declarations and policies expired, and really set us up to hit the ground running after those expirations. This group provided input and support in state policies and recommendations as well. And then lastly, for the tech side of things, we also coordinated yet another work group from IRT for technology focus. And this work group was led by OHI and Prime Health and catalyzed multiple projects to expand the use of telemedicine technology and data availability. Notable projects include partnering with Kinza, which is a public health company working to help individuals and communities to stop the spread of infectious disease and help respond to the threat of the pandemic by distributing telethermometers to several regions in Colorado. So we have distributed 15,000 smart thermometers that you can connect to an app and to those 3 communities of Aurora, Montrose, and Edwards, as well as a small number of Denver area preschools. And these 3 communities were chosen based on their demographic diversity, the density, location, and the illness spread, and were targeted toward first responders, families, and other folks who may not have access to the thermometers. I'm not sure if any of you looked for a thermometer in the early days of the pandemic, but most stores were sold out pretty quickly, especially in mountain towns or other areas that are usually not accessible for resources. We also launched, in conjunction with Prime Health, a regional remote patient monitoring pilot and learning collaborative to expand access to vulnerable individuals who are isolated at home. So IRT volunteers launched the COVID line, which was a pilot to provide a central point of contact and triage for telemedicine and in-person visits. To continue advancing these efforts and support the ongoing use of telemedicine, OHI is partnering with the state's 2 designated health information exchanges to fund 37 innovative telemedicine projects. We're working with the Colorado Health Information Exchanges, or HIEs, to advance the availability of health information between Coloradans and their providers, regardless if the visit is in person or virtual. All providers involved in these telemedicine projects are invited to participate in regional learning collaboratives facilitated by Prime Health to share best practices and learn from one another about telemedicine from a regional perspective. As we all know, Colorado is a very diverse state depending on where you live and what your lifestyle is. And so Prime Health was really innovative in thinking through how do we learn best from one another, and broke the state into those regions. And in that vein, we're working with Prime Health to establish these education and learning collaboratives, which will provide the opportunities for local providers to share lessons and best practices, not only from their transition to telemedicine, but also for this ongoing use of telemedicine. And last but not least, we are wrapping up the first phase of an evaluation in partnership with Colorado Health Institute to develop requirements and policy for the next evolution of telemedicine. This evaluation examines the value proposition of telehealth for Colorado and focuses specifically on access to care quality, patient and provider experiences, and sustainable business models. Through this evaluation, CHI engaged providers participating in the telemedicine projects I mentioned earlier, as well as a small cohort of patients to discuss their experience with telemedicine. We also convened the Telehealth Research Advisory Committee, or the TRAC, which served as the advisory group for this statewide evaluation of telehealth services. So at this time, we will turn to our partners with CHI to talk more about the evaluation and data used to inform the recommendations for telehealth. Thank you so much for the opportunity to share our work with you all today and discuss telehealth in Colorado. Carrie and I welcome any questions, and we've shared our emails here if you'd like to contact us to learn more or work together. So I'll pass it over to Nina.
Thank you, Stephanie. Hi, my name is Nina Bastian, and I'm a program manager at the Colorado Health Institute. I've been working with the team that has been evaluating the use of telemedicine during this rapid expansion period. So the goals of our project, as Stephanie mentioned, are to understand the value proposition of telemedicine in Colorado and to examine the effects of the state's COVID-19 telemedicine emergency response and policy changes. Our research uses quantitative and qualitative data to address questions across these 4 domains: utilization and access, provider business impact, patient and provider experience, and outcomes and quality. We can move to the next slide. For phase 1 of our project, which began back in June, the quantitative data that we analyzed was collected through the Colorado Health Observation Regional Data Service, lovingly known as CORDS. And the CORDS network contains electronic medical record data from 14 providers, representing about 32% of all Front Range residents. Our baseline time period for this evaluation was March through June of 2019, with the pandemic analysis period from March through June 2020. Our qualitative data collection consisted of 10 interviews with staff across 3 provider organizations in the state and 23 one-on-one interviews with patients. Can move to the next slide, thank you. Together with OHI, the Colorado Health Institute will be releasing 3 briefs summarizing key findings and policy opportunities for the future of telemedicine in Colorado. So I'd like to share a few of these high-level findings here with you today. With respect to the impact on providers, telemedicine has been invaluable in helping providers keep their doors open during the pandemic and will continue to be a key tool for serving patients as long as the pandemic continues to depress ambulatory care volumes. However, even as telemedicine encounters have increased dramatically, we saw that overall care use, both for in-person and telemedicine, dropped by 43% over the period that we analyzed. Can move to the next slide. We heard a lot of the same barriers for both providers and patients that Kristen shared earlier. Certain providers were better equipped to pivot to telemedicine. One of the highlights from our CORDS utilization data is that telemedicine has transformed behavioral health care delivery for community mental health centers. Telemedicine has the potential to dramatically change how behavioral health is delivered by increasing both access and convenience for patients. It is not a perfect substitute for an in-person visit, especially for patients with certain conditions. But community mental health center encounter volume did increase during the analysis period due to telemedicine adoption. We saw 84% of encounters were delivered via telemedicine during our analysis period, compared to less than 1% prior to the pandemic. Patients' experiences of healthcare encompass many factors, as we know. In this project, the Colorado Health Institute considered access to care, barriers to care, literacy, equity concerns, patient satisfaction, and the patient-provider relationship as factors that influence the patient experience in using telemedicine. While this project analyzed these factors separately, they are interconnected, and trends and patterns, of course, overlap. We found through our qualitative data collection that most patients with access to telemedicine consider it to be a great substitute for certain types of in-person care, such as health monitoring, some behavioral health services, and non-critical needs, while some also found it useful for urgent care concerns. Some do have trouble accessing or getting quality care through telemedicine. Oh, sorry, we can stick on this one, yeah. Accessing or getting quality care through telemedicine due to their circumstances, including things like limited broadband access and phone reception or specific health conditions. Most patients say they will continue to use telemedicine if available, even once in-person care feels safe. because of the advantages of convenience, time savings, and quality of care received. More research is needed to understand patient preferences for telemedicine once care does transition back to in-person. And we can go to the next slide. If these highlights have whet your appetite for information about our evaluation, I encourage you to keep in touch with OHI and the Colorado Health Institute in the coming weeks as these briefs will be released. CHI intends to continue working with OHI to leverage the CORDS network to take a deeper dive into certain conditions and service areas, including behavioral health, to expand and concentrate our patient and provider engagement, and also to consider a cohort analysis to better understand quality and outcomes. I'll also add that we're hoping to do additional analyses to stitch together the clinical data and insights from EMR data with cost data from claims. So I will turn it, am I turning it back over to the folks at Civic?
Awesome.
Okay.
Yeah. Thank you guys so much. Appreciate all of you guys being here and sharing all the great work that you're doing. Some of the reason I was going forward and back is I have lost my chat somehow and I can't find it, but I did see 2 chats before I lost it. And so I do know we have a couple of questions, and I might rely on Kristen or some others who might still have their ability to see their chat to see if anything else has come in. I know one comment was that there has been in recent months a drop off. So we saw from our sneak preview that there obviously was an increase in claims, which makes sense during the COVID period of time when elective services and the ability to go see a doctor was kind of halted. But then that there has been a decrease again. So I think that was more of a comment. I don't know if the CHI folks, if you guys have other information, since our claims data doesn't show that just yet because we don't have it yet, but any reflections on that?
I would, hi everybody, it's Sarah. I work with Nina at CHI. I would put a plug in for the briefs that we'll be releasing with OHI, hopefully next month, because I think that is true. We did see drop off on utilization of telemedicine, but not across all providers. And so I think that there are some interesting trends sort of looking at it sort of one level deeper, so.
That's great. Okay, thank you. And then I think the other one that I'm recalling, and it was a lengthy chat, but the gist was, does anyone have a sense of how our infrastructure in Colorado, better or worse, may differ from other states, making us a good or bad telehealth venue per se? I don't know if you guys were able to evaluate how we compare.
I actually happen to have a map of both Colorado and the country as far that ranks telehealth or broadband access. So if you want, I can share my screen and just show those 2 images.
That'd be great.
Let me pull this up real quick here.
Which is great because now I can see my chat.
So this is Carrie. I can say anecdotally that Colorado, or actually with our experience with federal partners, that we're a leader in this space, and a lot of the funded projects and coordination is unique. Not a lot of states are doing that, and in fact, Colorado is in a Western alliance with a few other Western states to figure out the best way to move it forward. But I'll hand it over to Kristen to talk about the pretty map.
The colors chosen on this is not I did not make this, so I'm not taking responsibility for the challenging colors, but the cooler end of the spectrum means there is more broadband access. The warmer end of the spectrum means less broadband access. And Colorado is right in here. So, I mean, we do still have a number of counties. Here's the Colorado specific look. We do still have a number of counties that are in that sort of red area that does have less broadband access, but we do have a lot of the state that has got much stronger broadband access than we're seeing in much of the country. So, I mean, we've got Alaska down here, Nevada, up in the Dakotas and Montana. Actually, the Dakotas look pretty good. Montana's got some really significant issues here too. So just so you have an idea, and I'm sorry about the challenging range of colors, but that gives you an idea of sort of where we're having, where we still have broadband challenges. And I believe this is 2018 or 2019 data, if I'm not mistaken. So.
I think the other portion of the question was also, are there other things that our providers are doing from an infrastructure perspective that might make us different? Are there pockets across the state, like Alamosa, for example? They're a rural area, but they have more use, and so are we unique in that we have pockets of innovation across the state and more happening on the provider side as well? Any insights on that?
Yeah, and perhaps Stephanie can do a deeper dive, but we tried to fund a number of, that we're going to be announcing here soon, a number of innovation projects across the state and rural and frontier areas, as well as the most impactful and equitable. Yesterday, we were talking with Access Health, and they're in Montezuma and Archuleta County, and they immediately went to leveraging telemedicine as quickly as they could for behavioral health, and we're spotlighting a few creative and innovative ways that they're doing that. And then on the Eastern Plains, we're seeing providers and payers gravitate towards that. I think where we're trying to figure out is what is the best way to weave all these pieces and parts together from a policy and payment side. But perhaps Stephanie, if you have any other anecdotes to share from just looking across all the various telemed projects that we're moving forward.
Yeah, I think you covered it pretty well. We'll have a better sense once they're underway of good stories to share and things like that. But agreed that it is pretty spread out throughout the state, and we have a few that are statewide as well that are not focused just on one area. So more to come.
Great, thank you. Kristen, this one might be for you. Do you know how broadband access was defined in those maps that you were showing?
No, I don't. They were sent to me by a federal partner, but I can certainly reach out and see how they're defining broadband access, and I can certainly get back to you guys.
Great, thank you. And then there's another question regarding, do we know of other states that are also tracking the kind of telehealth trends that we are looking at here in Colorado? And that's probably both from an APCD standpoint and then more of the qualitative, quantitative stuff that CHI is doing. Kristen, I don't know if you want to start in terms of from a claims standpoint.
I'm still, hold on.
Oh, you're good. I hear you.
I mean, we know that some of our APCD partners are doing a lot of work on COVID. I know Oregon is doing a lot of work. They've been doing some pretty robust tracking of their COVID trends. Who else? Ohio, I think. And then who else we worked with? Now I'm blanking. Oregon, Ohio, and then I think Maine is doing some work as well. A handful of states are. It's challenging from the claims perspective. Not a lot of states have got the level of robust access to claims that Colorado does, and so a lot of states are limited in the kind of analysis they can do just based on a lack of access to broad claims. So anyway, that's what I got.
Thank you. And I don't know, Sarah or Nina, if you know of any other efforts in other states similar to the work that you're doing.
So this is where I wish we would have invited our colleague Jeff Bontrager to be on the phone. Because he had put some work out earlier in the summer that was doing a bit more of a policy look and sort of taking that national scan. We were pretty head down, just trying to make sense of what was happening in Colorado. I don't know, Nina, do you have anything you'd want to add though?
No, I don't, but good to follow up on.
And I can share, so this is Carrie. One thing at a federal level that was released was this rural action plan to support the adoption and use of telemedicine across the US. So I think there's a lot more that's going to come out in terms of data, collaboration, and funding. But I put the link in the chat box for, actually I sent it directly to Carrie, so let me send that.
Here, I just sent it out. I got it. I sent it out, Carrie.
Yeah, but more to come from that. And as we publish our at least state findings, we'll definitely be reaching out to other states through our networks and venues to see how we compare, how we don't.
Great, thank you. Yeah, I think we have only 1 minute left. So Sarah Froelich, you had a question on the status of the ABCD budget. There was a little bit of funding cut for a majority of it came from our scholarship program, unfortunately, in the state budget. And we did see a little bit of funding decrease across our general fund contract, but we are still full steam ahead and finding ways to continue to make this an amazing resource now and in the future. So happy to share more information offline with you if you have deeper questions on that. But I would love to just thank everyone who was here today. Thank you to our panelists. Thank you to our attendees. Appreciate all the work that you guys are doing, and we will provide this recording as soon as we can. I want to hope you have all a wonderful, wonderful day, and thanks again for being here. Take care.